Welcome back. Introducing his budget vote, Health Minister Motsoaledi said his department wanted to ensure a long and healthy life for all South Africans. Life expectancy had taken a serious knock with HIV and AIDS and TB, a high incidence of maternal and child mortality, the burden of non-communicable diseases, and the high incidence of violence and injury, including motor vehicle accidents.
As a country, we started the early decades of HIV and AIDS on a wrong footing. But recently, in a typical South African style, we have bounced back. We have shown that collaboration and solidarity against a shared threat and a common goal is desirable and can produce desired results. Through combined efforts and collaborative undertaking, we launched a huge campaign to cancel and test 50 million South Africans for HIV. We have achieved this and even exceeded the target, and today, more than 20 million South Africans know their status. Through this program, we've been able to cancel and place 1.6 million South Africans on ARV. We have achieved this by increasing ARV sites from 490 in February 2010 to 3,000 in April 2012. We have increased the number of nurses certified to initiate ARV treatment from 250 in February 2010 to 10,000 in April 2012.
Dr. Motsoaledi said the new National Strategic Plan for a Healthy South Africa had integrated HIV and AIDS and TB. This new plan outlined a 20-year vision of the country in the fight against the double scourges of HIV, AIDS and TB.
The new NSP further states that every single South African must test at least once a year. We believe that if all South Africans can play their role, these goals will be achieved. We need to make sure that every pregnant woman undergoes routine HIV testing. We need to make sure that every male is circumcised, and hence this year we are targeting 600,000 men. On the issue of high maternal and child mortality, the high rates of pregnancy-related deaths, the disproportionate number of women exposed to sexual violence, with the worst incidence of all shame in the country just this past week, are a cause for concern. You will have noted, honorable members, that most of our interventions on HIV and AIDS are directed at saving pregnant women and children. It's important to know that maternal mortality is not just the death of a woman. It's the death of a woman because she fell pregnant. She becomes vulnerable to death because she's trying to bring a new life into this world. We know that even mortality brought by HIV/AIDS, as well as malaria, is disproportionately affecting young women of childbearing age more than men. This disproportionate assault on women of childbearing age is happening more on the continent of Africa than on any part of the world.
Dr. Motsoaledi said a number of steps were taken to address the efficiency and effectiveness of the healthcare system in South Africa. A government was seriously concerned about the deterioration of the quality of healthcare, aggravated by the steady increase in the burden of disease in the past decade and a half. This was also raised by the President in his 2012 State of the Nation address.
Since that time, Chairperson, we did not rest on our laurels. We also did not want to work on the basis of anecdotes or common sense in dealing with quality. Hence, we have embarked on a process of health facility audit. This entails sending teams to all the 4,200 public health facilities to audit infrastructure, human resources, cleanliness, attitude of staff, safety and security of staff, infection control, drug stockouts, and the long queues which citizens have to endure when visiting our facilities. Since we are at 90% towards completion of the audit, we thought we fully comprehend the nature of the problems. Hence, we have put up 4 teams of health facility improvement teams to go into these facilities to work with provincial management to correct all these anomalies and findings identified during the audits. The teams have already started working in Motsoaledi district in the Free State, Sidibeng in Gauteng, Zululand in KZN, and Priestley Kaseme in the Northern Cape. The portfolio committee is busy going through the draft legislation we have presented to them to establish the Office of Health Standard Compliance, which will deal with these issues of quality as described above, without fear or favor. Chairperson, I want to repeat, we would like the Office of Health Standard Compliance to deal with issues of quality of health standards without fear or favor.
With regard to the National Health Insurance, or NHI, the minister said there was no way the efficiency and effectiveness of the healthcare system can ever be realized without dealing with the cost of healthcare and healthcare financing. He said South Africa had reached a point of no return on the rollout of the universal coverage through NHI. Pilot sites had already been identified for introducing NHI. But for NHI to be successful, the quality of healthcare needed a complete overhaul, while pricing in the private sector must be regulated.
The success of NHI also depends on certain basics in healthcare being adhered to. We need to understand that the main reason for the existence of any healthcare delivery system is to take care of the sick and the vulnerable. Healthcare delivery systems do not exist to create millionaires at the expense of the health of our people. This tendency of putting business before health, yesterday I called it the tender care system because it's done in the form of tenders. It's no longer a healthcare system, but another form of uncontrolled commercialism, which the World Health Organization has warned us against. The manifestation of this tendency is the disappearance of funds from the most basic tenets of healthcare.
The chairperson of the Health Portfolio Committee, Monwabisi Gokwana, said there were special challenges in rural areas where healthcare was far less accessible than in urban areas. He said the only way to address it was through partnerships between public and private healthcare institutions.
If what we are talking about with the private healthcare sector, if it doesn't make good business sense to go to these rural provinces, I think we could think of public-private partnership. Chairperson, if as a country we are to meet the Health Millennium Development Goals, or we are to get the universal coverage that we want, we definitely need to look at the rural health. And we need to make sure, specifically looking at human resources, and even our budget must be skewed towards rural health. The oversight work we do covers the whole health sector, private and public. But the point that I want to bring here is that there's always seems to be this paranoia between the private healthcare industry and the public healthcare industry. I think for all of us, the vision is the same. So we need to make sure that we find a way of making sure that this divide is done away with so that we can have good health indicators. South Africa has other stakeholders in the health sector. I always mention this, that in South Africa, 70% of our people are still attending traditional healers. And I don't think they can be ignored. Whether they're doing the right thing or they're doing the wrong thing, for us to be able to meet what we want to meet, we need to make sure that we engage them in one way or another, even making sure that there are proper regulations that are going to deal with. This is something that we find in our oversight.
After the break, we recap on some of the issues raised during the NCOP public hearings into the Protection of State Information Bill. Stay with us.